Thank you so much. At this point of our research day, we're going to move into our first panel presentation and discussion. And now I am very pleased to introduce Dr. Candice Gregnini. She is the research node leader for the community-based lifestyle intervention node of the AIR-P Research Network, and also the associate program director for UCLA Preventative Medicine and associate physician diplomate at UCLA Health. Candice, thanks so much for moderating this panel, and thank you also to the panelists.
Thank you so much, Dawn, and thank you all for joining us today for our first research day as with AUCD and as the AIR-P. It's my pleasure to be kind of hosting and moderating this section of the research day today. With us, we have the leaders of the Healthy Weight Research Network, and I'll introduce them in a second. And so just to kind of orient you to what we'll be doing for the next little bit of time together, we'll have the leaders of the Healthy Weight Research Network provide a presentation, and that will be followed by some insightful commentary and discussion led by Patrick Dwyer. He's one of our ARRB members and a PhD candidate in developmental psychology in the Neurocognitive Development Lab at the Center for Mind and Brain at UC Davis. And then we'll open it up to questions from you, the audience. So now it's my honor to introduce the Healthy Weight Research Network leadership, Drs. Linda Bandini, Carol Curtin, and Aviva Must. Dr. Bandini is the principal investigator of the Healthy Weight Research Network and an adjunct clinical professor in the Department of Health Sciences, Programs and Nutrition at Boston University. Dr. Curtin is the director of the University Center for Excellence in Developmental Disabilities at the University of Massachusetts Medical School, Eunice Kennedy Shriver Center, and co-director of the Healthy Weight Research Network. And Dr. Must is the Dean of Public Health and Professional Degree Programs at Tufts University and co-director of the Healthy Weight Research Network. So please join me in welcoming Drs. Bandini, Curtin, and Must, and I will pass it over to you guys.
Great. Can everybody hear me? Good. Yeah, so I'm Carol Curtin, and both Linda and I are going to do this formal presentation, and our colleague Aviva Must is in transit, but will be available for the question and answer and discussion part of today's presentation. And I just want to say that we are thrilled and honored to be asked to be a part of today's research day, and we're particularly pleased because our research network has a lot of synergy with what AIR-P is doing, and we have just received our next 5 years worth of funding, and so we look forward to a lot of opportunities in the future to collaborate with AIR-P and other colleagues around the country. And so today we were asked to do a presentation on obesity in autistic children and youth. This is a very deep, rich topic, so we're only going to be able to touch on the highlights, and we'll present a little bit of data that we at the HWRN have collected, as well as other researchers around the country, and hopefully have some fruitful conversation after we do this formal part of our presentation. So next slide, please. So before we get into talking about obesity in the autistic population, we just want to put this in context in terms of obesity in general. And as folks probably know, it's a pretty complicated, complex, and multifactorial phenomenon that has genetic, environmental, and psychosocial factors. And you may be aware that there are social determinants of health that increase risk for some segments of the population. There are racial and ethnic differences. People in poverty have an increased risk for obesity compared to the general population. And we also see this in the autistic population. And Alice alluded to the fact that, the autistic population is a health disparities population, and that's really been a focus and a concern for our work. Obesity in children and adults is associated with physiological and psychosocial consequences. and it increases the risk for adult obesity and all of its comorbidities that go along with it. And that in general, in an oversimplified way, obesity is the result of a positive energy balance where energy intake, we very often refer to as calories, over a long period of time is greater than energy expenditure or burning calories. And that seems quite simple, but it's actually pretty complicated. And it's particularly relevant when we look at the world that we now live in, which has been called an obesogenic environment, meaning that a lot of environmental factors predispose us to be in that energy imbalance state. And as a consequence, and we'll show you some of our data, the risk for childhood obesity may in fact be greater in autistic children than their age-related peers. Next slide, please. And so this graph really shows obesity trends in children between the ages of 2 and 19 years since 1963 to 2018. And you can see that the rate goes up over time. And many people know from watching TV and reading the newspaper that, obesity is a problem that people in the United States in general face, including children. Next slide. So the question is why? Why have we seen this increase over time? And the increase has been pretty dramatic. If we had a longer time to present, we could show you some very compelling maps that show the increase in obesity over time among people in the United States, but it hasn't been long enough to really be explained by genetic changes in the human genome. So a lot of what the current thinking is that this is due to many, many environmental factors, and we'll just talk about a couple now. Next slide. So one of the things that has changed since the 1960s, which is when we started to see this increase in weight status, is that food now is everywhere. If you look at these images here, back when I was a little girl, when you went to the gas station, you got gas. Now you go to the gas station and there's a full supermarket there. And if you start to pay attention to your environment when you go places, you will see that there is food just about everywhere in every store. I don't have an image here, but I did take an image one day of going to Kinko's to do some copying and mailing, and there was a big candy display in the Kinko's store. So this is really a phenomenon that we've seen over time. The proliferation of food everywhere. In addition, low quality foods are often inexpensive. We live in general in a more complex food environment. There are many more food choices that one makes and a lot of confusion over what's healthy and what isn't healthy. And unfortunately, high calorie foods are heavily advertised to children. Next slide. We also see that there have been changes in trends in spending on food over time, such that food consumed at home has been increasingly or has been decreasing, while food eaten away from home has been increasing. And we know from other data that food eaten outside of the home is more highly caloric, higher in fat, and also, as we'll see in the next slide, there has been a real increase in serving sizes in foods eaten outside of the home. So there have been trends that people are eating outside the home more often than they had been. And this slide basically shows that the average restaurant meal today is more than 4 times larger than that in the 1950s. So you can see here that the average size of French fries back in the 50s was 2.4 ounces, and now it's 6.7 ounces. Hamburgers are 3 times the size that they were in the 50s. And then soda has really just taken off and is about 6 times the size that it was back in the 50s. So we're eating more outside the home. And then when we are outside the home, the portion sizes are considerably larger. Next slide. We also see that at the same time that there's been a change in what and how and where we're eating, we also see on the physical activity side, the energy expenditure side, some changes in physical activity levels among children. Next slide. And there are a number of environmental factors that have been found to be associated with decreased physical activity, fewer safe areas for children to play, a lack of safe areas to walk, for example, sidewalks, the use of cars in favor of walking or biking. And in the last 30 or 40 years, the suburban sprawl has contributed to this, that in order to get anywhere, one needs to ride in a car versus walk or ride a bike. And then certainly we have seen that the proliferation of computers and other screen-based technologies really does promote sedentary behavior, sitting and looking at screens. So these are factors that have changed and have increased over time, which are associated with decreased physical activity. Next slide. And we see actually that the proportion of youth getting the recommended 60 minutes of physical activity per day is pretty low. So children should be getting 6 minutes of active physical activity per day. And we see from a study from the National Survey of Children's Health in 2016 that just about a quarter of youth were reaching that criterion. And then another study using NHANES data saw that these physical activity participation starts to really go down over time. And this was data based on accelerometry, using accelerometers to directly measure engagement in physical activity, such that under half of kids 6 to 11 years were meeting the guidelines. And then over time, 7.5% of children ages 12 to 15 were meeting these guidelines. And by the time kids are 16 to 19 years, only 5.1% were meeting these guidelines of 60 minutes of physical activity per day. So physical activity, or the lack of it, is also a significant factor that puts kids in energy imbalance. Next slide, please. So what do we know about obesity prevalence, dietary patterns, and physical activity in autistic youth? Next slide. So here we have some data on the global prevalence of obesity in youth with autism. And you can see that overall it's a little over 20%. And then you have different prevalence rates according to different regions. South America looks particularly high, but I want to point out that that was only 2 studies. And North America, where we have 30 studies, shows that the obesity rate is about 23%. And that's high relative to typically developing children, which also have a high prevalence. And we'll see what the difference is in a minute on our next slide. So here are a series of analyses of the prevalence of obesity among children with autism from nationally representative samples. And you can see that the dark blue bars represent the autistic population, and the green bars represent kids without autism. And you can see that in every case, the prevalence of obesity is higher among children with autism than it is for kids without autism. and hovers around 23%, except in our study, we saw it at 30%. Whereas in general, kids without autism have a prevalence of obesity, anywhere from 12 to about 16%. And overall, most studies show about 16% in the non-autistic population. So we really see a difference here. Next slide. This is another study that we did at the Healthy Weight Research Network using data from the National Survey of Children's Health. And this is a somewhat complicated slide to follow, but the bar charts at the bottom half of the slide show the prevalence of obesity in children with and without autism. The dark blue is the autistic kids and the lighter blue is kids without autism. And you do see actually that the prevalence goes down for the typically developing kids over time, which we do see in some of the individual age groups in nationally representative surveys, although it goes back up in adulthood. But the prevalence actually remains unchanged in kids with autism. And so what you see in the graph on the top of the slide is the adjusted odds ratios of the fact that as weight starts to go down a little bit in the typical population, it remains the same, and therefore the risk of obesity in kids with autism increases. Now, we don't really have an explanation for why this is, but it does speak to the fact that whatever the factors are that may be accounting for some decreases in the prevalence of obesity in the typically developing population, those factors do not seem to impact the lives of children with autism. And so this shows that they start off heavier and they stay heavier, and that there may be factors that do not advantage them in the way that may be advantaging the typically developing population. Next slide. And similarly, we also see that along with obesity, there are health-related or obesity-related health conditions that kids with autism experience compared to kids without autism. And I want to say that the y-axis on this slide is wrong. So this is not a prevalence estimate. This is actually rate per 1,000 children. So I apologize that this slide is wrong. And so these are rates per 1,000 rather than percentages. But it still shows that the rates for obesity, type 2 diabetes, hypertension, and hyperlipidemia, as well as non-alcoholic fatty liver disease and non-alcoholic steatohepatitis is higher in kids with autism than in kids without autism. And so not only is the obesity an issue, but also the comorbidities that go along with it. And next slide. And similarly, one of our colleagues at the University of Kansas, Lauren Tomey, and her colleagues took a look at data from the University of Kansas Medical Center. And they did a whole variety of comparisons of kids with autism, and also had kids with Down syndrome and other disabilities. But among kids with autism, the prevalence in that data set was 17.5% of the sample had overweight, and then nearly a quarter had obesity. And among those with overweight and obesity, they saw or observed increased risk for sleep apnea, hypothyroidism, or hypertension, and these are in children. So we see nearly 3 times the rate of sleep apnea, and hypothyroidism, and then a fourfold risk for hypertension compared to those without overweight and obesity. So we're seeing that, these medical comorbidities are significant and really speak to the need for understanding this phenomenon in autistic youth, and then developing interventions to prevent and then also to intervene on obesity. Next slide. So I'm going to turn the slide presentation over to Linda, who's going to talk about risk factors. So we've gone through what the risk factors for all of us are in this obesogenic environment that we live in. But we see that autistic individuals may have additional unique risk factors in addition to these risk factors that we're all exposed to in our environment. And so I will turn it over to you, Linda, to complete the presentation. Thank you.
Thank you, Carol. As Carol mentioned, autistic youth live in the same obesogenic environment as typically developing youth, but in addition to those risk factors limited on physical activity, being exposed to high-calorie foods, there are we think some other factors that may be contributing to the higher rates of obesity in this population. Could I have the next slide, please? And some of these are on both sides of the energy balance equation. So energy intake may be impacted by food selectivity, by sensory sensitivity, by behavioral problems, using food as a reward, sleep patterns, and use of medications. And I'm going to talk a little bit about each of these. Could I have the next slide, please? On the other side of the energy balance equation is energy expenditure. And we think, again, that some factors that may be unique to autistic youth are delayed or impaired motor skills, sensory sensitivity, behavior problems, and barriers to physical activity. And I'll talk about these as well. I just wanted to give you a sense that there is the energy balance equation is energy intake and energy expenditure. When they're in balance, weight remains stable. But if energy intake exceeds energy expenditure for a long period of time, excess weight gain will occur. So on the next slide, there are some data to suggest that feeding problems are greater in children with youth with autism than typically developing youth. And this study was done by Will Sharp published in 2013. It's a meta-analysis and a systematic review looking at feeding problems in autistic youth. And you can see there are, I think, about 12 or 13 studies here. And overall, they found that autistic youth had a 5-fold greater level of feeding problems than did their peers without autism. And many of these feeding problems are considered to be related to food selectivity, meaning that they're eating less variety of foods, have a more restricted repertoire. Next slide, please. And this is some data from our children's activity and mealtime pattern study that we conducted about 10 years ago. And we gave parents a food list of 133 different foods. And we asked parents to check off whether their child would eat that food or whether their child refused the food. And you can see here in dark blue are autistic youth, and in light blue are typically developing youth. And you can see that the numbers of foods refused by autistic youth were significantly more than those without autism. And similarly, they refused more vegetables than typically developing youth. We don't know if food selectivity is related to weight status, but most of the foods, or many of the foods that these children are refusing, are fruits and vegetables. And we do know that there is an association between fruit and vegetable intake and protection against chronic disease, and may be related to weight status. But this study was cross-sectional, and so we can't say that there was a relationship between fruit and vegetable intake and weight status. In fact, there wasn't, because we looked at it in this study. But we really need longitudinal studies to determine whether or not children who are refusing fruits and vegetables and not eating eating many, whether that's related to weight status. Can I have the next slide, please? So on this slide, in the same CHAMP study, in the same children and activities and meal pattern study, we also looked at dietary patterns. And in addition to having differences in food acceptance and food refusal, we saw here that autistic youth were eating less fruit than their typically developing peers, eating less vegetables than their typically developing peers. And these were statistically significant. We also saw that they were having more sugar-sweetened beverages and more snack foods, but these were not statistically different. So what this suggests is that not only are they refusing more variety of foods, but they're eating less fruits and vegetables. And that may, in fact, be a risk factor for obesity. But as I said before, we need longitudinal data to look and examine whether or not it is a risk factor. So next slide, please. So I also wanted to mention that behavioral problems at mealtime may influence parents' food choices and what they feed their child. And that may they may give them what they prefer, and that may also often not be the most healthy option. Additionally, food is often used as a reward in behavioral programs for good behavior. And again, those may not, we don't know, but that may increase energy intake and may be associated with weight status. We need to do more research to see whether or not there is an association between using food as a reward and weight gain. Sleep problems are common in children with autism. And in the general population of children, it has been shown that shorter sleep duration and obesity have been found to be associated. Again, we need more research to know whether or not these sleep patterns in autistic youth are related to weight status. Another risk factor is the use of medications such as second-generation atypical antipsychotics. These are associated with weight gain as well as elevated levels of metabolic syndrome. So I'll have the next slide, please. So I talked about some of the factors that are associated with energy intake, potentially food selectivity. And food selectivity is often related to sensory sensitivity. Children who refuse fruits and vegetables may not like the texture, they may not like the feeling in their mouth, the crunchiness. But we also think that sensory sensitivity may impact on physical activity as well. So what factors may affect energy expenditure are physical activity and physical activity associated with impairments in motor impairments, sensory sensitivity, barriers to physical activity and behavior problems. So in our CHAMP study, we asked the parents to fill out a questionnaire about barriers to physical activity. And we asked them about 6 different barriers. And you can see here that the dark blue is parents of autistic children, and the green is parents of typically developing children. And you can see that the number or the percentage of parents who reported behavioral problems limiting their access to physical activity was significantly higher across the board for both behavior problems, motor problems, social skill difficulties that would impact on their ability to participate in a physical activity. Many parents reported that the adults who ran these activities lacked the skills to include their child into the program. Many parents reported that other peers excluded their child. And in their community, many parents reported that there were inadequate opportunities for physical activity. So lots of barriers, including motor problems, behavior problems, social and communication problems, all that impacted on the ability of their children to participate in physical activity. So this study was done with children 3 to 11 years of age. And on the next slide, you can see the data from another study we did in adolescents. And we asked a very similar type of question to the parents on a survey, again, asking them about the barriers to physical activity. And you can see here that 90% of parents reported social skill difficulties in comparison to 8% of typically developing youth. 97% reported that they had few friends to do physical activity with. 49% said that adults don't make their child feel welcome. And 74% said of the adults said their child, that the adults who were running the programs lacked the skill to include them. And 74% explained that the peers excluded their child. So you can see that there are many factors that parents reported were barriers to their child actually participating in physical activity. So we see both on the energy intake side of the equation, food selectivity, using food as a reward, medications that may include weight gain because they increase appetite. And on the other side of the energy balance equation, barriers to physical activity, which may prevent a child from participating and then using less energy overall. So we really, these are some unique barriers that we are looking at, and we really feel that need more investigation to see how they contribute to weight status in youth with autism. So on the next slide, oops, I guess I forgot about this slide. This just shows you the difference between the percentage of kids in our two studies, the young children on the left and the older children on the right. This is the percentage of autistic youth meeting the recommendations for 60 minutes of daily physical activity. And you can see that for the 3 to 11-year-olds, only about 23% were meeting their requirements compared to typically developing kids who were over 40%, and even less in the adolescents, where only about 15% of autistic youth were meeting the requirements. More data to support the need for increased opportunities for physical activity. So next slide, please. So what can we do about weight management and helping autistic youth to maintain a healthy weight? There haven't been a lot of studies to help youth who are already overweight or obese reduce their weight. I know this slide is really difficult to read. There's about 9 studies on here. Most of them are cohort studies or clinic-based studies that included children with special needs and autistic youth in their programs. There are only 2 studies that were actually randomized controlled trials that actually have been done with autistic youth. And they were very small studies, but they did find encouraging weight loss in the program, as did these multi-component clinic-based programs. So there is encouraging data to support weight management programs that are adapted specifically to meet autistic youth, the needs of autistic youth, and to promote healthy weight. So on the next slide, please. So in summary, autistic youth are at an increased risk for obesity. They have low physical activity levels and inadequate intake of fruits and vegetables. We must remove the barriers, the social and community barriers, to promote good health and inclusion of autistic youth in physical activity opportunities. And we need more research on the biopsychosocial determinants of health disparities in youth with neurodevelopmental disorders overall. And weight management programs for autistic youth need to be developed and tested and really adapted to meet the specific needs of the population. And overall, everyone has a role to play in promoting healthy lifestyles for autistic youth. Next slide. So I mentioned as we went along that we think these risk factors that affect both energy intake and energy expenditure may be unique to this population, but most of the studies to date have been cross-sectional. So we really need more studies and more longitudinal studies to see if these factors do impact on weight status in autistic youth. But we also need more research on obesity prevention and weight management programs for autistic youth. And we need multi-component interventions that include nutrition, physical activity, as well as behavioral strategies. And as I mentioned previously, really these programs all need to be adapted to the needs of autistic youth to address the barriers to healthy eating, such as food selectivity, the barriers to physical activity, including motor competence, and providing messaging, nutrition education in a simple and clear manner. Thank you.
Thank you so much, Drs. Bandini and Dr. Curtin, for your excellent presentation. And I wanted to go ahead and reserve the remaining few minutes of this space and pass it off to Patrick Dwyer, one of our Autistic Research Review Board members, for his thoughts and discussion on this very important topic.
Well, thank you very much. This is not my field, so it's an honor to be asked to discuss this. I know that I usually, when somebody is discussing a talk, just want to get to the interactive Q&A, so I'll try and be succinct, but also I do tend to ramble, so I apologize in advance if I'm not. But I really appreciated these talks from Linda and Carol, and especially their focus on all of these societal issues and barriers, the social determinants of health, both those associated with autism and those, operating in general. I think that is really, really important. And it's also interesting how those intervention programs that we were briefly looking at in that last table, seem to be a bit more focused on individuals and families. So I think that, to me at least, really begs the question, what can we do to ensure that we're working, both on providing support to specific individuals and families and on these big picture societal issues like the overprescription of the atypical antipsychotics, the sensory and social barriers to physical activity. And those societal barriers, they're big and complicated, and maybe it's hard to quantify effects of programs on weight outcomes and everything, but really that seems to me to emphasize that that's an important area where we need to be doing more. Another thought I had, which may be a bit more idiosyncratic to me, is that final point that Linda was saying, that everyone has a role to play. It made me wonder, what is the role that different people have to play in this area? And, as somebody who was once an autistic child growing up, not that long ago, I feel like there's definitely, a possibility where you can have a situation where there's adults around the autistic individual who are really pressuring them to be more healthy, whereas the autistic individual, is facing all of these additional barriers from society, like the sensory sensitivities that, encourage us to eat, lower limited number of safe foods, often those carbohydrate type things. So we're dealing with that. We're, also perhaps dealing with autistic burnout or, mental health struggles or all sorts of things. And then maybe, this doesn't become as much of a priority. And you could even see that maybe the person is getting into the habit of resisting other people's efforts to promote greater health. And what's the long-term effect of that if we're, instead of building up somebody's internal motivation to be healthy, we're instead getting them in the habit of, defensively resisting other people's efforts to get them to be more healthy. So how can we, in these programs, promote a lasting motivation to be healthy, and extend that into adulthood? The focus of a lot of these programs hitherto in the field has been on children, but what about adults? Well, not fostering motivation to the extent that we're encouraging eating disorder type behaviors, which obviously is another serious intersection in relation to autism. So, perhaps, all what I'm trying to say in this last bit here is getting back to the talk's really excellent focus on understanding these barriers. Maybe this points to the importance of continuing that important work that Linda and Carol and others have been doing in getting perspectives of all the relevant parties here and figuring out, what those barriers are and what, their experiences of them are. So there, that's what I had to say. Let's move on to the interactive discussion bit now. Thank you again for this opportunity, and also Linda and Carol for that great, very comprehensive introduction to a very large and complex topic.
Thank you so much, Patrick, for all of your insight and expertise and kind of lending your thoughts on what Linda and Carol and Aviva have prepared for us today, and really kind of, you know, again, re-emphasizing the need to kind of bridge these gaps also in the way that we think about, you know, obesity and obesity research, and really kind of reframing it in terms of it's something that affects all populations, right? Autistic populations, non-autistic populations. And again, there are special considerations. And so kind of highlighting the need to really focus efforts on taking those into consideration and kind of maybe revamping some of the ways in which we've been delivering services or education or curriculum or sports, so they are more appropriate and engaging and relevant to autistic youth, and can help them build like healthier habits too as they age into adulthood and transition to independent living. And so, Dawn, I wanted to see, I know Alice typed a question into the box, and I wasn't sure if we had time for our panelists to discuss that today, or if we need to move forward in the busy schedule. So I wanted to ask before I bring it up.
The schedule is busy today, and we are running a little bit behind. If we could address Alice's question and keep the Q&A short to that, I think we'll get back on time.
Okay, great. So I'll go ahead and read Dr. Kuo's question that she typed into the chat box. She was wondering if you all could please comment on whether you believe that interventions to address obesity in autistic children should focus more maybe on social determinants, such as discrimination based on disability status, et cetera, or individual issues. So overcoming perhaps sensory and textural challenges that many autistic youth deal with. And kind of alongside that, where would you see our prioritizations need to be in terms of research dollars, since funding is always quite a limitation when we're trying to study and evaluate these things?
So thank you. I'll take that question since I was not able to be part of the presentation. So thanks for Carol and Linda for allowing me to jump in late. So I think, you know, talking about the social determinants of health, I think is primary in terms of the way we think about interventions. I think with respect specifically to thinking about discrimination based on disability status, I feel like that's in the health policy realm, and there certainly is health policy relevant research to do. But I think within the Healthy Weight Research Network, we've been thinking more about individual, family, social, school contexts, healthcare contexts, and maybe community contexts, and have not, at least previously, thought about more federal policy kinds of interventions. Clearly, they're all important, but I'm not sure that the research enterprise is really structured in a way to really move the policy needle as the main intervention point. You know, as Linda and Carol, I think, have explained pretty persuasively, there are lots of levers here to think about in terms of everything from food selectivity and sensory sensitivity to mealtime context to family context, peer influences. You know, there certainly are issues that affect all children around food insecurity and housing instability and other broader societal social determinants of health. But I think would continue to prioritize thinking about the needs of the autistic community and some of the particular challenges that they may face in the physical activity and nutrition realms as primary drivers. There's also interesting work to do, I think, around sleep as a potential risk factor that may be particularly important in children with autism. I don't know, Carol or Linda, if you want to add to that.
This is Carol. I would just add that when I look at those barrier findings that we had, one thing that we have to do is make sure that adults can successfully include and welcome kids in physical activities. We have to really work on peer exclusion. The fact that those things are barriers to me is unacceptable. And we have to make it easy and enjoyable for kids to participate. You know, that people will participate when it's easy and enjoyable, and we have to do that for kids with autism. And that's why we say that everybody has a role to play to really facilitate peer acceptance, peer inclusion, adult awareness, adult skills, so that kids can be a part of things in their community and not face barriers that you know, have nothing to do with their motor skills, but everything to do with the extent to which they're welcomed and included.
Thank you so much, Dr. Must and Dr. Curtin, for those incredible responses. And I just wanted to, again, thank all of our panelists and Patrick Dwyer for joining us today. And if you guys have contact information that you wanted to put in the chat box, or a website, say for a Healthy Weight Research Network, or any ongoing work or studies that you guys are doing, please feel free to put them in the chat box so people in the audience can go out, learn more about what you're doing, or contact you if they have questions about the work that you do, or perhaps have some interesting collaborations they'd like to propose.
Sure, we'll be happy to do that right now.
Thanks so much. And I will pass it off for the rapid fire presentations.
Thank you so much. That was an excellent panel and discussion. I appreciate everyone's contributions to that. We are going to move into the rapid fire presentation portion of this meeting, and we're pretty